The patient response to imatinib is always assessed at 3 months. In this case, the patient had a 10% of PCR, which is under the limit of what the patient should have. However, his doctor decided to really wait, and many times we do, to the 6 months mark to really see if this 10% continue to decrease, which will be the best outcome for most of the patient. 6 months, this patient experienced at 6%, which is really an appropriate level. However, at 9 months, we start to really see that this PCR start to really go back to 9%. And finally, at 1 year of therapy, it's very clear that this patient has failed therapy based on a bone marrow evaluation and the persistence of 10 out of 20 pH positive metaphases in the bone marrow. This is really considered lack of complete cytogenetic response that is the optimal outcome at 1 year of therapy. So in this case, we should consider this patient as a failure to imatinib therapy. And of course, we at this point need to really understand why this patient failed. So his doctor prescribe and perform this kinase domain mutation to assess if there is any able mutation responsible for the lack of effectivity of imatinib. In this case, as happened in many occasions, at least in 50% of the times, there was no mutation found that can really justify this lack of response to imatinib. Anytime that a patient relapses or lack to achieve the right milestone as per the NCCN guidelines, a kinase domain mutation should be performed. Kinase domain mutation evaluates the presence of specific mutation in the able part of the BCR-ABL protein that will enable tyrosine kinases to really bind and effectively treat the patient. In this case, there is several mutations that has been described through the last years. Many of them can really be of lack of importance. However, there is specific mutation that at some point may respond to one drug versus another drug. It's well characterized, however, that there is one mutation. Tyrosine 315I is a mutation for which none of the tyrosine kinase inhibitor except ponatinib is effective in the treatment of this condition. Other mutations like a 255 or 259 or 359 are mutations that can also manage with other drugs. Unfortunately, the presence of mutation may predict the onset of new mutation later on, so it's something that needs to be taken into consideration. Once a patient fails imatinib at front line, they have multiple options for the treatment as a second line. We are lucky enough to really have at least 4 drugs available for the treatment of this patient, and even we can add, in some cases, a chemotherapy drug that is very rarely used in this setting. The drugs that they are really can indicate will be nilotinib, dasatinib, bosutinib, and ponatinib. And the choice of any of these drugs will come for the potential comorbid conditions as well as the efficacy of these drugs in patients with resistant CML or at least to refractory CML to imatinib.